Good morning, afternoon, and evening, and thank you all for attending today's webinar sponsored by the ATS Assembly on Allergy, Immunology, and Inflammation, and de facto with the Behavioral Science and Health Services Research Assembly. My name is Ruby Nusrat at the University of Michigan, the organizer and moderator for today's discussion titled Optimizing Inhaler Technique Teaching. We have three uniquely qualified speakers who will remind us how to teach patients how to use their medication inhalers. I will keep the introductions brief because full introductions of our accomplished faculty will leave no time for the educational content. The faculty members have made sustained data-driven contributions demonstrating that adequate teaching of inhaler use results in reduced acute care needs. Dr. Valerie Press is at the University of Chicago and the current chair of the Behavioral Science and Health Services Research Assembly. Dr. Costello is with the Royal College of Surgeons in Ireland. Dr. Riddell is with the Woolcock Institute of Medical Research and the Macquarie University in Australia. And you may follow her work with the asthma guidelines. Here, the COI. The overview is basically about the whys, hows, and whats, and each of the faculty members will go over each of these individually. For example, Dr. Press will discuss the prevalence of inhaler misuse as a form of unintentional non-adherence and present a guideline-driven educational approach that is expected to be effective across health literacy levels. Dr. Costello will discuss the relationship between adherence and inhaler technique. Dr. Riddell will discuss how to sustain effective inhaler technique and how to train the trainer. In other words, how to train those individuals who will then be teaching the patients. In the end, I will help moderate the QA session. Just remember to submit your questions in the chat function. With that, Valerie.
Great. Thank you so much. I appreciate that great introduction. So we want to set the stage. I'm showing here just an example inhaler, and I actually have a video that I'm going to pull up and show you. Hopefully the sound will work. We tested it.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Sure.
All right, so we'll go back to the slides. So now that we've set the stage, clearly some patients do not know how to use their inhalers. So it's not just some, it's a lot. So we wanted to set the stage about why we want to talk about inhaler misuse and how to teach. So I'm MedPeds trained, and so I will be sharing some information that's both pediatric focused and some that's adult focused. So in this study by colleagues of mine at the University of Chicago, they looked at an educational strategy, which I will be talking about with you in a moment. But at baseline, before they did any teaching, they found that almost all of the children using respiratory inhalers demonstrated some element of incorrect technique. It was rampant. And this is in a space where self-management education is often part of the standard of care, meaning we're trying to teach children how to use inhalers. Similarly, in adults, work that I've done and work that others have done, this is just one of my studies, but there are hundreds of studies, including people who are on this panel, have shown that adults also fail to use their inhalers correctly much of the time. The 86% here represents meter dose inhaler or pressurized meter dose inhaler among hospitalized patients. And so they're a particularly high risk group. And so inhaler misuse, take my word for it, is highly prevalent. So the way to fix it is to teach patients, but that sounds so easy, but it's not. So how do we do that? There is an approach that that was just stated earlier that is guideline concordant. What does that mean? Guidelines suggest that we should be teaching patients how to use their inhalers and also actually assessing their technique at all healthcare encounters, that inpatient or outpatient. So this is a handout that one could use. Handouts are often the sort of standard for patient education. If patients don't get handouts, they might just have to go to their package inserts. Sometimes there are videos, and sometimes they're lucky enough to have a human teaching them. But most of the time, regardless of what it is, it's static. It's not dynamic or interactive. So this would be what would be considered a brief instruction, especially if you say read it out loud. What I want to talk about is teach to goal. Teach to goal is that guideline concordant strategy that's helpful across health literacy levels. So here, don't worry about the details. This is just a figure that shows that there are multiple different steps for different types of inhalers. As we all know, inhalers come in different shapes and sizes. And so we developed standardized checklists that can be used to isolate each unique step. Here, we're representing the pressurized meter dose inhaler with spacer, and also a checklist for discus, which is one of our dry powder inhalers. What I like to do when I go through these steps with patients or when I'm training trainers is talk about how not only are the steps different, but sometimes they're in direct conflict. So that if you only train on one device, they may just take that information and move it to the other. For instance, with a meter dose inhaler, hopefully they're using a spacer, but either way, that medicine comes at them quickly. So they need to kind of breathe it in nice and slowly. Where with a powder inhaler, right, they're the ones inspiring it in. So it has to be more of a brisk inhalation in. So we have checklists to isolate each of those steps. Here's where the guidelines come in. We don't start by teaching, we start by assessing. So that checks the box for that part of the guidelines. So you watch what the patient can do with their inhaler. Then you can provide in the moment tailored verbal and physical demonstration of how to use the inhaler, all of the correct steps. You can highlight what they did well. You can highlight the steps that they needed to work on. And then you use this health literacy concept of teach back, where you then say, I've tried to show you how to do this. How good of a job did I do? Show me what you would do now. And you can go through the cycle until you're at goal. There is different ways you can look at this. So some people, might want perfect technique. So they would have to get, say, all of the steps correct. These are just two of the example types of checklists. We've used more of a misuse cutoff where there's a little bit of wiggle room. What we care about is not how good they look doing it, but how the medicine gets into their lungs. But it's not neither of these are perfect, but you can choose which way you want to do it. But either way, you pick your goal and then you work toward that. And then finally, there's actually a cognitive psychology phenomenon behind why teach to goal may be more effective at teaching and having them retain the information, and that's called the testing effect, where memory is enhanced when you're interacting with individuals during the learning process and sort of testing them. It maps it differently than if you just say, read them some steps and then move on. So here are some data that show that teach to goal that I just showed you, that is what the sort of gold standard is in my mind, compared to brief instruction that I showed you, that handout that we just read out loud. So if you see at the top, both populations, brief instruction in light blue and teach to goal in dark blue, were above 80% misusing. That's very similar to what I showed you just a moment ago. Immediately after teaching, multiple rounds of teaching for teach to goal and one round for brief instruction, both groups actually improved, but you can see that the teach to goal group did much better, with just around 10% still struggling after the teach to goal. And then what we just wanted to show is that one and done is not enough. This is skill-based education. The exact dosing, how many times over what period, is not known, but it is known that we need to do this multiple times, which is why the guidelines say at every healthcare encounter. And then finally, I just wanted to show a little bit of the so what. So I said, what doesn't matter is how good they look, right? That's the inhaler technique, what we're seeing. What matters are the outcomes. And so one way to look at that is, did this impact acute care visits? So if you look at a composite of acute care for either ED visits or hospitalizations, for those who got the teach to goal approach, there was significantly fewer events at 30 days. When we looked 3 months out, that had disappeared, with the caveat that we did not provide additional education, because at the time we didn't know if we needed to. We do know that now. So this just reinforces that need to do repeated doses of education along the way. So with that, I want to pass it over to my colleague, Dr. Costello.
Hi, everybody. I just wanted to make this one quick point. There's a real relationship between adherence and technique, and a real reality to this, because, you know, many times people listen to a lecture like Dr. Press has just given, and they think to themselves, well, that must be somebody else's patients, because most of mine seem to be struggling on and getting by. So I want to tell you a little story about a patient of mine. So some years ago, my research team and myself developed this clinical and engineering project where we said we'd put some numbers to the whole idea of inhaler technique and proficiency of inhaler use amongst patients. And so I was responsible for the clinical aspect. And what we did was we developed a small acoustic recording device that would sit on top of an inhaler. I'm just going to take that slide back one section, Valerie. And this recording device allows you to analyze, or allowed us, or a computer, I should say, really, to analyze how proficiently the individual had used their inhaler. And of course, it was timestamped, so we could tell when the patient had used their inhaler. And what I wanted to show you is an example of one of our patients. That was taken some time ago, but on the y-axis, you can see times in the 24 hours. And along the x-axis, you can see the days. And this individual, where the little yellow spot is an individual who has COPD, who is going home from hospital. And we wanted to see in this particular project how their adherence was after they went home. Because as you know, there's a financial or there's a clinical impact of readmission from COPD exacerbations in the first 30 or 60 days afterwards. And we wanted to know, is poor adherence or poor inhaler technique a big feature of patients who get readmitted? So what you can see here at the first, on the March 23rd, the individual was trained by our team, didn't do very well, I have to say, probably didn't use as much teach to goal as we could. And then a month went by, and because it was this device that we were developing, and it wasn't Bluetooth, it was fairly basic, we had to actually get the patient to send us back. And Valerie, could you show the next slide? And so we got the inhaler back, and you can see the acoustic recording device on top of the discus. But unfortunately, you can also see a little cigarette burn there right in the middle. And what we can take from that was we learned that the patient hadn't given up smoking. So we knew that they'd had their inhaler nearby, but we certainly learned that they hadn't done particularly as we had wanted. The only other time that they used their inhaler was the day they sent it back to us. So, you know, we've got some serious non-adherence, and both times that they used their inhaler, they used it correctly. Valerie, can I have the next slide? When our COPD outreach, which is a home visiting team, went to see the patient in her back bedroom, we found this huge collection of medicines. Because what happened was that this individual, this lady, was bereaved, and she was lonely, and she really was struggling with all aspects of her health. But particularly, all she really wanted was her sleeping tablets. And she had a bunch of medical insurance delivered treatments that she just wasn't engaging in. So why I'm showing you this slide is to give you a real kind of sense that inhalers and their non-adherence and their poor inhaler technique has a real story behind it. But to put numbers on that, and Valerie, could I have the next slide, please? We looked at several hundred patients, and we classified them into 4 groups. And I'm just going to take you through that. So the first cluster, which is a dark green, took their inhaler really, really proficiently and really regularly. And along the x-axis, we have days of survival, and the y-axis shows the probability of death. And you can see that the people with the dark green line had the best outcomes. The next group have a slightly lighter green, and they're the ones who took the inhaler very, very regularly, but with poor inhaler technique. And you can see this is a cohort of COPD, and unlike I would imagine with asthma, this graph shows that there's really only a small benefit of inhaler proficiency, and that more reflects the condition, COPD, which is often quite resistant to an ICS-LABA, which is what we were testing back a decade or so ago. But what starts to become interesting is the next group. So cluster 3 in this sort of dark mauve color took their inhaler relatively irregularly, but when they took it well. And then the red line with the odds ratio of 3.4 of having a bad outcome took it both irregularly and when they did take it, they took it very poorly. And that is a huge signal that these individuals have something unique about them. They're not taking their inhaler well, and they're not taking it very often. And they're just like that lady I showed you in the previous slide. And what we identified when we looked at all the characteristics of these patients, their COPD was the same, but the two factors that came out was that they were living alone and they had high levels of anxiety. So what you can see in that, I think, in that slide, what that message said to me was, if people are taking their inhaler regularly, and if they're taking it well, or if they're taking it regularly and they're not even taking it terribly well, they've got much better health outcomes than people who don't take it very often and don't take it well. So what that is telling us is that inhaler technique and adherence are both giving you a message about the individual as much as anything else. And what I think I would say, if I had a magic wand, is I'd love to be able to do an intervention and say, well, let's target each one of these, target the ones who are not using it and not doing it well, and really spend our money on that. And that raises the question, which I think is most important. And Valerie Press just mentioned it, and I think Dr. Riddell is going to take this up next. How often should we be testing? Should we be looking out for these people in the red cluster 4? Should we be looking out to see if these people exist? And should we be doing inhaler training once or several times? And so to answer that question, I'm going to ask my colleague, Dr. Riddell, to tell us about how often we should be doing inhaler training.
Thanks very much, Richard and Valerie, and Remy, for the opportunity to join in this webinar. So I'm just going to share my slides. And I will just scroll through to where we're up to. Apologies for this delay. Okay. Sorry, I should have had this ready at the right spot. Nearly there. Okay, so the first thing I'm going to talk about is how to sustain inhaler technique. Excuse me. So Valerie has shown how inhaler technique drops off quite quickly. It's particularly important after an admission to hospital. Or when you see the patient for the first time, because a huge amount of information is conveyed to the patient, and the fine details of how to use their inhaler might be done at the end of the visit or at the end of the consultation, and it may just be lost in the number of things that we've expected the patient to remember. So one of the important things is to know, when you've trained the patient using that teach to gold technique that Valerie explained, how can you keep that going? So as background, I'm going to show you one of the first studies we did quite a long time ago, where we taught inhaler technique to a group of pharmacists. So this was actually a sham-controlled cluster randomized study where we taught pharmacists how to check inhaler technique, and the control group of pharmacists were taught how to check peak flow technique. So the pharmacists didn't know that there was a particular difference between the groups. And then the pharmacists themselves they went out back to their practice and they recruited patients who were attending their own pharmacy and taught them how to use their inhaler, and then followed them up over the next 6 months. So you can see in the bottom left there with the discus what the patient's inhaler technique was like. You can see a mean score there out of 9, so very low, as we always find in these sort of studies. In the control group, it was slightly better at 6 months. And in the group that came back and saw their pharmacist and had a regular check and retraining of their inhaler technique, you can see that at 1 month, very much better than at baseline, almost perfect. And then with another check the next month when they came back for their next inhaler, and again at 3 months, even better still. And you can barely see the error bars there, so there was almost no mistakes made. And then 3 months later, so mistakes were starting to emerge there. Now, you can see on the right here the one of the clinical outcomes. We called it asthma severity at that stage. This is nearly 20 years ago. We would call it asthma control these days. And in the active group, you can see that the proportion with severe, assessed as having severe asthma, was quite high at baseline, and that gradually improved over the first 3 months and only slightly worse at 6 months. And that compared with the control group, where there was no difference in the assessment of their asthma control over that time. So in this study, just as a reminder, so the pharmacists would assess the patient's technique, educate the patient about particularly focusing on the incorrect steps, and then they would do that again repeatedly until a maximum of 3 or until technique was perfect. And what we found in that study, that it actually didn't take long. It was less than 5 minutes the first time, and it got down to about 2 minutes with the later checks. Now, one of the unique things about this study, which was actually developed by the PhD student pharmacist whose project this was, she developed some very simple labels which had a brief description of the inhaler technique on them, and I'll show you an example in a moment. And so the pharmacists would have this label, and they would stripe with a highlighter pen the particular steps that the patient had incorrect when they were first checked at that visit. And that label was stuck on the inhaler. So there's an example with a discus. So this patient didn't breathe out before they put their mouth on the inhaler, and they didn't inhale forcefully and deeply. So later on, when my colleague was back in Jordan, where she came from, she did a study in her own community looking at the effect of training patients with the label attached and without the label, so that we could see whether it helped in the longer term, because we all knew that you had to keep on checking and checking. So what this shows, again, is a low score on the discus at baseline, a marked improvement with the teach to goal technique. And then, so the solid line here is their technique out at 3 months later. And you can see that it's gone down by 1 point on average. And that's less than the decrease in those who were trained here, but didn't have the label. So this is a really low-tech way of helping to maintain the correct technique once it's sought. But it does emphasize this issue that you do have to keep on checking and checking. In my clinic in Sydney, Australia, we try to check technique at every visit. And the way that you go about this depends on if this is a patient that you're familiar with, that you've seen many times before, or whether it's someone you're seeing for the first time. And we use the same technique for pharmacists and nurses. But let's come now to the question of, well, how do we teach the teachers? How do we train the trainers? So I'll just skip through those slides there. So first, preparation. So if you are going to set up a program to train the trainers, it's really important if you can try and get a set of placebo inhalers for the most common types of inhalers that you are going to prescribe or check. So obtaining placebo pressurized metered dose inhalers is usually fairly easy. Dry powder inhalers, it's a bit harder to get them, but they're gold when you can get them. So if you get a placebo inhaler, write your name on it with a felt tip pen immediately, because then you know that you can keep on using that to demonstrate correct technique. Even if the patient doesn't have their inhaler with them, you can at least show them how to use it. So you need the placebo to be only for your own use. One of the most effective interventions we've done was a session at our National Respiratory Conference one year, where the organisers had collected a set of placebo inhalers for all of the common types of inhalers in Australia at that time. And they had these in a bum bag, and my goodness, those were prized so much by the participants. So the next thing you need is a set of inhaler checklists, and Valerie has indicated that there are various sources for these. The information about inhaler technique that is inside the packet of an inhaler is not usually useful. So it's a very flimsy piece of paper, usually folded up multiple times, and it's covered with dense information in a tiny font. So if at all possible, source checklists, for example, in the references at the end of this list, at the end of this presentation, I've given a reference for a website in Australia where we've got checklists and videos, but what I hope is that there will be similar sources here in the US. The second is expertise. And so you need to actually practice using the inhaler yourself. You don't realize how challenging it is to do one of these multi-step processes until you try and do it yourself. So practice with a colleague, check each other's technique back and forth. What you need to be able to do is to practice the steps until you can actually describe them without the checklist. Because taking an inhaler doesn't take very long. And you can't say to the patient, well, show me how you use your inhaler, and then you're constantly looking down to check if they're doing it correctly from the checklist. You need to know these checklists off by heart and be able to describe them and replicate them in demonstration without the checklist. And then for expertise, I'd really encourage you to watch videos, not just of how to use the inhaler, but how to teach it to patients. And then expectation is really important, because in your practice, you need to encourage all staff, not just the doctors, not just the nurses, to accept checking of inhaler technique as absolutely routine. This is as important as prescribing the medication. And then the other expectation is for patients. You want to remind them to bring their inhaler to the visit so that you can actually watch the way that they use their inhaler. In my clinical practice, it's the most exciting moment of a new consultation, because in just a few seconds, you can see, okay, I know what the problem is here, or nothing to see here, this patient's using their inhaler perfectly. There's a big difference in what you do next after you see that. In terms of who is going to be the trainer, so we have done a lot of work with pharmacists, because when you think about it, the pharmacist is the last person that the patient sees before they go home with the inhaler. And they usually have to go back to the pharmacy each month or each 2 months to get a new prescription. So the pharmacist is in a unique and special position of being able to intervene regularly with patients for inhaler technique. So how do you ask the question? So this is really important. So if Dr. House had said, do you know how to use your inhaler? He would likely have got the hands-on hip indignant, or else a slammed door. That's not the question to ask, because most patients have been using these inhalers for a very long time. They get absolutely insulted if we ask them if they know how to use it. And in fact, in some of our studies, we've actually asked patients first, are they confident that they're using their inhaler correctly? And it was 90% were confident in how to use it, and 20% could actually use it correctly. So that's not a good question to ask. And I think Dr. House's question was actually a really good one. Why don't you show me how your inhaler works? Non-critical. So that's just that's avoiding a confrontational start to the process. And another one that you might use is, can you show me how you use your inhaler at present? So you're not implying that this is the way they always use it. You're saving them from embarrassment if they demonstrate technique and they've got errors. It's just how they used it at the moment, while we know that it's more likely how they use it regularly. So what do you say if when you check their technique, it's absolutely terrible? So, if when they use a puffer, a PMDI, you can see the little wisp of medication coming out the top of the canister, you know that they have not got any of that at all. If they don't open the inhaler or prime the inhaler, you know that they've got nothing. And there are many, many different errors in technique, some of which are major and some are minor. But what do you say next? So you don't say, that's the wrong way to use this inhaler. Sometimes you feel like laughing hysterically because their technique is so wrong. But you, again, need to be really compassionate and careful about what you say. So you can see that in the little video clip, she said jerk as she went out the room. So, I don't have the lovely eyebrow movement of Dr. House, but we need to know what to say to the patients. So this is my suggestion. Can I show you a way to use your inhaler that will make the medicine work better for you? So think about the gain for this patient. So this is where you take into account what they've already told you about their asthma or COPD. Do they need better symptom control? Do they need fewer exacerbations? Or have they got a lot of local adverse effects, such as thrush or dysphonia? So what's in it for them will make this sort of a statement, how the medicine can work better for you. It's personalizing the whole issue for them. So then the other interesting thing that we found in our study of pharmacists, so remember, we trained the pharmacists, we got them to check each other's technique, repeated it until they knew they could do it correctly. We provided them with checklists so that they could then recruit patients and train them. And the control group of pharmacists were trained in how to teach and check peak flow technique. So it was a sham controlled trial. So then we actually went back 2 years later and checked the pharmacist's technique. And what we found was that technique in the pharmacists who'd done the active intervention, so the study had long since finished, it had finished a year earlier, they still had almost perfect technique themselves. Compared with the pharmacists who hadn't been trained in technique, they had improved a bit over time. So what we realize is that if a health professional is checking their patient's technique and comparing that with a checklist, it helps to maintain their own skills. So this is a highly efficient technique for training the trainer, because you're not just training them at one point in time, you're actually training them, or they're training themselves, every time they check a patient's technique. So again, this is a really low-tech solution. And it reduces the need for retraining. It absolutely magnifies the potential impact of the work that you can do in your clinical practice. The other point I've got here at the bottom, though, is watch out for new dry powder inhalers. So pressurized metered dose inhalers are pretty much the same. Sometimes they will have a different cap. Sometimes they'll have a dose counter or not. The dose counter might be in a different place. But usually the technique with a pressurized metered dose inhaler is the same, and new ones tend to look the same as the older ones. However, with dry powder inhalers, and this is particularly a problem as generic medicines become more common, that dry powder inhalers are usually different from every single device to every other one. And so you need to keep your eye out for what are the new inhalers that my patient is likely to have dispensed when they go to the pharmacy, and make sure that you know how to use each of those correctly. Some of them have little quirks of what you do first in terms of priming, and there's all sorts of different aspects to the dry powder inhalers. And I just want to emphasize a point that Valerie made, that the technique in terms of the strength of inhalation is very different between a PMDI and a dry powder inhaler. And so if a patient has a PMDI for their reliever, but they have a dry powder inhaler for their controller medicine, you've instantly got them having to use different technique with both of them. And we try to avoid that if possible, but it's not always possible. So sometimes I write with a felt pen on the inhaler, fast or slow, for the dry powder inhaler and the puffer respectively. We know from many studies that if patients have, the more different types of inhalers a patient has, excuse me, and especially if they have different types of inhalers, that the more likely they are to have incorrect technique with both of them. So patients who have two different inhalers, it's really important to focus on their technique. So just in summary, in training the trainer, preparation. So think about who is going to be trained and how to do it. We need to embed it in medical school, in pharmacy school, in nursing school, and in expectations for training. So make sure that you have the equipment to be able to check and correct patients' inhaler technique. Practice until you can use them perfectly. So if you're prescribing a new medication to a patient and you pick it up and you sort of fumble and you look at it and, you know, how do I use this? That's not going to imbue your patient with confidence in your expertise in other areas, not just in inhaler technique. Make sure you can do it perfectly yourself. And then that expectation that checking and correcting inhaler technique should be absolutely routine. So just recently I had an experience with a patient I've been seeing for 20 years. So at the end of the consultation, I said, oh, I didn't check your inhaler technique. So I knew her well, so she wasn't, you know, that was okay to say. And she literally put her hands on her hips and she said, Dr. Riddell, do you know how long I've been seeing you? So I said, oh, look, humor me, just do it. And she did it, and she pulled out the inhaler, and there glowing at us was the red empty signal on that inhaler. So we both had a great laugh, and it just reminded me that we have to keep on checking. So communication, how to ask the question of the patient, really critical. You don't want them to slam the door in your face in terms of inhaler technique. And then how to react when you see what they're doing. It's important that we teach these skills of compassionate communication to all of our trainees so that they don't stumble in terms of alienating the patient. And then the absolute importance of maintaining your own skills in the face of what seems to be an expanding range of different types of inhaler. So now I'm going to hand back to Rumi to host the Q&A session. So I'd really encourage you to put questions in the chat so that we can go through them and address whatever concerns or questions you have. Thank you.
Well, it's quite the tour de force from our faculty. While we were waiting for questions, I just thought I'd pose the following. Are there groups of patients in your mind, this is to any of the faculty members, where we would give a dry powder inhaler versus a meter dose inhaler?
I'm happy to jump in, but I would have to. So I always try to make sure that we start by giving the medications of choice and then train on the inhaler type. but there are considerations. And so in the US, a lot of the inhaler choices are made by insurance. But if we have pure control, aligning device type. So if there's a controller and a rescue that are the same type, then you only need to train on one. That can be advantageous, as Helen was mentioning, especially with the dry powders. They're all a high variety. There are other things like dexterity and strength. And so you have to be able to breathe in quickly enough for the powder with enough force. So that's something to consider for some patients who might not be able to do that. Some patients have problems with their hands, arthritis and other things that might make a pressurized meter dose inhaler difficult. And then there's also the type of device where it's actually nebulized, which is great, but to get the medicine into it, it takes a lot of strength to get the canister in. So I think it's just considering the whole patient and what their various needs are, in addition to, at least in the US, insurance. And then I see Helen has a point to make as well.
Yes, so just to add to those comments, so in children 5 years and younger, usually it needs to be a pressurized meter dose inhaler with a spacer. So that group we don't expect to be prescribing dry powder inhalers to. The other group that tends to not necessarily be able to use a dry powder inhaler is the very elderly or those who've got muscle strength problems. So essentially, you need to see what inhalers are available to this patient. And in the US, I know that that what is available to them may actually change every year. So what's available, and then start with the one that you think is most likely to be appropriate for them. But if they can't use it after a couple of rounds of training, you need to consider a different device.
I just will add one more, and I completely agree with what the other two faculty members have said. Severe hyperinflation and COPD, they're unlikely to be able to generate sufficient inspiratory force over this dynamically hyperinflated chest, and so they may not be able to deaggregate the powder within a dry powder inhaler.
And I just want to bring up as med-peds, I'm really glad, Helen, that you mentioned masks, and for children as an age group. We underutilize them also for older patients or any patients that have dexterity issues. So spacers should be for all, masks can be for anyone that it would help them.
Well, with Richard's comment, we have a comment from the audience, and I think this will be targeted towards Richard's skill set particularly. Kelly Lyle is asking, and Kelly, I'm going to paraphrase your question. I hope you don't mind. Kelly's essentially asking, how about the inhalers with technology built in? What's your take? In the US, Kelly Lyle is observing that one of the technology-linked inhalers has been taken off the market because of various reasons. Richard?
Well, you know, I don't know. I can't speak to the particular reason why that technology was withdrawn, but it certainly looked very promising in its development. I think that technology really has a role in two very important places. The first is, as the faculty, both Valerie and Helen have said, if you do the basics well and repeatedly, you're going to get excellent outcomes. But there's always a group of people who there's a doubt in your mind. And I was making the point that there are some people who make errors and then they say, look, I'm just not doing this, or they can't learn. And then there's a group of people who are trying and not managing. But, you know, at certain points in prescribing, you've got some big challenges. You know, I mean, I'm thinking of an asthma patient in whom you might be thinking, look, they're not doing well with the high dose ICS LABA, and you're thinking about a biologic. That's a very expensive step up. And so, you know, this is the perfect point to bring in an inhaler technology monitoring for a period of a couple of months. You can see, particularly if you combine it with the measurement of home spirometry, digitally acquired, you can really tell if this person is uncontrolled and yet adherent. And then that should be a no-brainer barrier overcome for getting access to a biologic, rather than relying on kind of more passive measurements like pharmacy pickups and self-reported control when you're making a decision that has such financial implications and such sustained implications, because a person going on a biologic for some period of time. I think the other place is on COPD folks going home in the first 30, 60 days. Are they taking the inhaler? And then maybe you're getting a bigger window into their into their health behaviors in general sense, like I was showing with that really tragic case that we picked up on this, on that individual. So they'd be the two places I'd use those technologies.
We have a question from Param Oat. Have you found differences between asthma versus COPD patients in terms of patterns of inhaler use? Is there something we can glean from disease? I should say broadly.
Can I just jump?
Linked.
I'm going to jump in there. I think a physician's job is to make a diagnosis. That's our primary role. And there are two diagnoses we make. One is the kind of the pathophysiological process going on in the individual. And the second is in who is the individual that we're dealing with. And if you sort of say, well, asthma and COPD are both airways diseases, they bother people, that's one thing. But there's such a range of people, whether they've got asthma or COPD. So I think the issue here is in who are we dealing with? And if they've got learning issues, or if they've got memory issues, or got anxiety issues that mean they can't learn or they can't hold information, then we've got different training strategies or little alerts in our head to say, like Helen said, repeated training, repeated reinforcement. So I think it's just as important. What's probably more important than the differences in disease, which I don't think there's much difference in adherence and inhaler technique between the two populations. There's certainly a big heterogeneity in humans.
I'd like to add to that. So there's also an age effect so patients with COPD are often older than patients with asthma. But we've talked about the importance of training and repeating that training. When you think about it, if this patient may have been using this inhaler incorrectly for many years, they've reinforced incorrect technique once or twice a day for many years. And so to actually interrupt that cycle and embed a new muscle memory in them is going to take repeat. So it's important not to be discouraged if the patient's not doing it correctly the next time you see them. The next time you see them, you've got the opportunity for, you don't have to go through all of the things the first time you saw the patient. You can focus on inhaler technique. But so it's not a failure to teach correctly necessarily. It's that you're trying to overcome many years of habit. And that's why I think the inhaler technique label, that very low-tech solution, was good, because instead of saying you've got to do these 12 things correctly, you're narrowing it down. Look, you did great on most of these steps. There's just 2 that I want you to really focus on. And if you can use visual communication, so this is where demonstrating, explaining why this step is really important, getting them to go over and over that. This pays off in heaps in terms of future healthcare costs. And particularly in the case when you're considering biologic therapy for patients with severe asthma. And now this is in the space for some patients with COPD as well. So even the cost of a single injection of those biologics would be far greater than the cost of implementing one of the new connected devices. So if you're trying to, for your health system, if you're trying to make an economic justification for using inhaler technology, then start with those patients with the most severe disease where you've got a very expensive treatment option. You can make the case there and then work backwards to the more general population.
That was great. And I'll just add that that was, I think the main topics that were just said were spot on. I'll just add that in some of my studies, I'll enroll both patients with asthma and with COPD. And when we stratify by disease, we don't really see much difference to get at that kind of specific question. Inhaler technique is rampant, but patients can learn. If they can't learn because of memory or other issues, then you adjust. So I just wanted to say that we have actually looked at that.
There's a specific question from Saba online, who is asking, how important is it for the patient to hold their breath after taking the inhaler?
Very.
So you're getting down to the brass tacks of the technique.
Yeah, one of the most, I think my colleagues will agree, one of the most commonly missed steps, even for patients who otherwise have really excellent technique at baseline, is that they, don't empty their lungs first. And if you just think about your lungs being full, how can the medicine go in? Holding the breath is what allows the medicine to make its way down the airways. And if you just take it in and open your mouth, as Helen alluded to earlier with seeing the mist, it'll go out, you'll end up eating it, or it won't have the opportunity to really make its way down the lungs.
So in addition, if you, particularly with a dry powder inhaler where you want a strong, long inhalation, so the holding the breath actually helps to avoid patients just doing a short, sharp inhalation that's too short to get the medication out. So it's part of a suite of steps that together bring optimal delivery. But I agree that breath holding is important, but also important to breathe out all the way first.
We have a question. Go ahead. Richard, are you going to make a comment?
All right, one minor point, without trying to confuse faculty, one error that does happen when you follow along too much on that concentration of breathing out before you breathe in is once you've primed the dry powder inhaler, if you exhale onto the dry powder device, you're just going to get a wet, moist.
Breathe away from.
I live in a very wet part of the world, and our salt devices are always full of moisture, and you can shake the salt cellar and nothing comes out, even though you can see it's full. And I sometimes think of the inhaler as a bit like that. So they have to make sure that they exhale and then prime the device.
And I want to highlight at least in the checklist I showed you when I said we make discrete steps. A lot of the checklist kind of clump things. We actually made a separate step to not just breathe, empty your lungs, a separate step to do that away from the device. So they get separate credit. So they get credit for emptying their lungs, but if they breathe into the device, as Richard said, that's a problem. So
Valerie, you used the word checklist.
Yes.
And there's a question in the chat asking for what's a good place to find checklists. Mm-hmm. And I want to ask our program coordinator a question. When the video is made available, is it possible for us to put links that the faculty would recommend?
Yes.
Okay. So,
yes.
So Saba, we'll have an answer for your question. We will have information available as the program becomes available through the ATS system. So that there are several checklists, and I think because our faculty is global, I would imagine that a number of different sources will eventually end up on our website. So hold your question.
I'll just add, Helen alluded to the reference slide, which we haven't actually shown you, but there's a slide after the Q&A slide that has some of the references. So she has checklists, and then I also have an example of that MDI discus checklist. But yes, we'll add links. Rumi, thank you so much for suggesting that.
Yes, now we have something from pediatrics. So I think it's kind of important that people are pushing forward with questions. The question is, in the pediatric population, what age do you expect the children to become responsible for using their inhaler? So I think they're asking is broadly, when do you focus away from the parent to the child?
Great question. I'll start, and I'm sure others have ideas. So in Illinois, children have the right to carry their inhalers at school, meaning it doesn't have to be in a locked box in the nurse's office, because the nurse isn't always there. They don't always have nurses. And the answer is for the child to be responsible for their own inhaler is when the parents and the clinicians think they're ready, which can vary, but often in the later elementary school ages, and certainly by kind of the middle school, junior high ages. In terms of who to teach, definitely the parents for the younger kids, both if appropriate, even if it's early for the child, just to be there and kind of understanding if they're going to kind of co-manage. But as Helen mentioned earlier, the mask with the spacer for children is generally 5 and under. So parents are going to be helping out for at least age 5, often through 6 or 7. But by 7 or 8, children are usually able to do some of their own inhaler taking, even if they're helped by their parents sometimes.
Yeah, Benjamin, I forgot to take your name. Thanks for asking the question, Benjamin. Go ahead, Helen.
Oh, sorry, just in terms of encouraging adherence and the patient taking responsibility, you really want that transition from the parent being responsible to the child being responsible before they get near to teenage years. This is not a point on which you want teenage rebellion to be manifest.
Yeah. We have 4 minutes left. I think we have one question, and then we can the faculty can decide how to wrap up, and I need a minute for the thank yous at the end. So the question is now about the pharmacist, and Helen, you have talked much about it, but for the question is coming from Leslie Hendlis. The pharmacist is an important source, as has been discussed. Leslie is just referring to the use of refill as a proxy to check for adherence, and this is linked to pediatrics. I know there was some discussion, so could you just speak out loud as to what the value of the pharmacist in terms of using them as a proxy for adherence, etc.?
So what you can learn from refills is the maximum amount that the patient could have been taking. So you don't know if they've refilled the medication. You don't know whether it's actually sitting in the drawer in their home, or as Richard showed in that devastating photograph. But at least you know that that they had access to the medication. It's the maximum amount they could be taking. So I think we have different levels of granularity in terms of asking patients, of finding out how much they could have taken. I've mentioned the way that you ask the question about inhaler technique. And similarly, you need to ask in a very careful, non-confronting way about adherence. So in the GINA report, we suggest a strategy where you sort of start with the worst option. So I'll say to a patient, over the last 4 weeks, have you taken it any at all? Have you taken it, say, 1 day a week or 2 days a week? So start at the bottom to give the patient permission to admit to not taking it, because once they're comfortable with admitting that, then you can have a discussion about, well, how can we improve that? So yes, if the inhaler has not been picked up from the pharmacy, it's a really important indicator that they're not getting any.
Thank you. I think our time is up. I'd like to thank our amazing speakers. I'd like to remind the audience that it is 7 a.m. in Sydney and 10 p.m. in Dublin. I think that our amazing international faculty has really supported this. I think it is their passion, their appreciation of how important it is that they have committed their time to their inconvenience to help out, I think, what is a global concern. And thank you, Valerie. And for those of you who asked the engaging questions, of course, the web committee of the Allergy, Immunology, Inflammation Assembly will think carefully about what might be next steps for us in our educational effort. Tetsuro, do you have any comments to make before we close off?
No, I do not. I just thank everybody for organizing this amazing webinar.
For the audience, please don't forget, please contact the ATS Assembly web representatives. You can look them up online for suggestions. I think we improve with feedback. So we are open to your thoughts and how we could improve our effort in this global effort. And with that, I'd like to say everybody good morning, good afternoon, and good evening. This is such an amazing privilege for us.
Thank you. Bye-bye.
Goodbye.